Okay, we're going to continue with Chapter 48, Part 4. When discussing birth and developmental defects, we're going to start with developmental dysplasia of the hip, also known as DDH. It's formally called congenital hip dysplasia or congenital dislocation of the hip. Usually occurs about 1.5 per every 1,000 live births. Girls are more commonly affected. There's typically a strong family history. 3 degrees is known as the acetabular dysplasia preluxation, which is the mildest form. In this degree of DDH, there is osseous hypoplasia of the acetabular roof and the femoral head that remains in the acetabulum. Subluxation is a degree in which there is an incomplete dislocation of hip. In dislocation, the femoral head loses contact with the acetabulum and is displaced posteriorly and superiorly, and the ligaments are elongated and taut. So some of the clinical manifestations would be in the infant: hip joint laxity, shortened limb on the affected side, restricted abduction of hip on the affected side, unequal gluteal folds when the infant is prone, positive Ortolani test result, and positive Barlow test result. In the older children, the affected leg appears shorter than the opposite. There is marked lordosis and waddling gait. So look at box 48-5 on page 1549 of your textbook. So let's talk about therapeutic management of DDH. Early intervention is of great importance. Birth to age 6 months, the Pavlik harness for abduction of hips. Age 6 to 24 months, dislocation unrecognized till the child begins to stand and walk. There should be a closed reduction and a spica cast. And in older children, operative reduction, tenotomy, osteotomy, and then the corrections very difficult after the age of 4. Clubfoot is a complex deformity of the foot and the ankle. There are several different forms, but the most common are the talipes varus, that's an inversion or bending inward, talipes valgus, that's eversion or bending out, talipes equinus, that's a plantar flexion with toes lower than the heel, talipes calcaneus, that's a dorsiflexion with the toes higher than the heel, and then there's the talipes equinovarus, and that's toes are lower than the heel and facing inward. This is the most common form of clubfoot. Clubfoot may also be positional, mild, or postural, and it's thought to occur due to intrauterine crowding. Positioned or mild clubfoot may correct spontaneously or may be corrected with passive exercise or serial casting. Syndromic, which is tetralogic, is a classification in which clubfoot is associated with other types of congenital anomalies and is a more severe form of clubfoot that may be resistant to treatment. However, it usually necessitates surgical correction. Then we have congenital, that's idiopathic. It's a classification of clubfoot in which there is a bony abnormality and always necessitates surgical intervention. I actually had a cousin years ago that had congenital clubfoot. So let's talk about management. Correction and therapeutic management occurs in 3 stages: the correction of the deformity, the maintenance of the correction until normal muscle balance is regained, and the follow-up to avert possible reoccurrence. Then we have the Ponseti method. That's the serial casting. This is what my cousin had experienced. It begins shortly after birth, consists of weekly sessions of gentle manipulation and serial long leg cast to allow for gradual foot repositioning. They are casted until correction is achieved, and it usually takes around 6 to 10 weeks. Okay, let's take a look at skeletal limb deficiency. It's also called reduction malformation. There's a wide range of severity, consists of the underdevelopment of skeletal elements, may be causes by constriction by amniotic band, which may cause prenatal destruction of the limb. Other associated abnormalities may be present. The types are amelia, that's the absence of the entire extremity, macromelia, that's the partial absence of extremity, and the focomelia, that's deficiency of the long bones with relatively good development of hands and feet that are attached at or near the shoulder or the hip. Therapeutic management is going to include prosthetics as early as possible. Early prosthetics encourage the maximum exploration and development in the infancy stage. Focomelic digits, see the pictures to the right of the slide for an example. They may be surgically modified, however, they are typically preserved for use with a prosthetic. Now let's talk about osteogenesis imperfecta. It's a group of the heterogeneous inherited disorders of connective tissue that's characterized by excessive fragility and defects of bones, defective periosteal bone formation and reduced cortical thickness of the bones, and then there's hyperextensibility of the ligaments that is present. So let's go into the classifications. We have type 1. There's type 1A, that's a mild bone fragility, blue sclera, normal teeth, hearing loss. Type 1B, that's the same type as 1A, except they have abnormal teeth. Type 1C, same as type 1B, but no bone fragility. And then it's also an autosomal dominant inheritance. Then we have type 2. It's lethal. Usually have stillbirth or death in early infancy. There is severe bone fragility with multiple fractures at birth. It is an autosomal recessive inheritance. Then we have type 3. This is severe bone fragility. Leads to severe progressive deformities. They may have normal sclera, marked growth failure. Most causes is autosomal recessive inheritance, and by some cases autosomal dominant inheritance. Type 4. We have type 4A, that's mild to moderate bone fragility, normal sclera, short stature, variable deformity, and it is autosomal dominant inheritance. Type 4B, same as type 4A except abnormal dentition. And then we have, it accounts for approximately 6% of cases of osteogenesis imperfecta. Look at box 48-6 on page 1553 of your textbook. Okay, we're going to continue with some more classification. We have type 5, which is similar to type 4. It's a hyperplastic callus, negative collagen mutation involved. Then we have type 6. It's moderate to severe bone fragility. We have type 7 and 8. We have osteochondroplasia and short stature. Therapeutic management is primarily supportive care, intravenous bisphosphonate therapy, and you may rule out osteogenesis imperfecta if there are multiple fractures occur. Rehabilitative approach for prevention of further complications. Our goals of treatment are to prevent positional contractures and deformities, prevent muscle weakness and osteoporosis, and prevent malignment of lower extremity joints. Surgery is sometimes used to assist with the treatment of manifestations. Children with osteogenesis imperfecta require careful handling to prevent fractures, and they must be supported when repositioned or moved. Look at your nursing alert on page 1555 of your textbook. This concludes Chapter 48, Part 4.